further, I'll pass you across and hope you enjoyed the session. Cheers.
Oh, thanks, Craig. So what I'm going to do today, we don't have a foot model here, but a hand is roughly the same, as you know. So I'm going to start laterally and work my way around anteriorly, back around the back, and go through all the different things that can go wrong with foot and ankle. Because I think when I graduated anyway, basically any ankle that came into the clinic, it would just set its ATFL and hope it got better in about 4 weeks, and not all of them did. So there's a lot more things that can go wrong, and a lot of them are easy for us to pick up, and a lot of them go missed, especially in emergency departments and GP clinics, because they will send people, get an x-ray comes back normal, and then 10 weeks later the person goes back and sees the GP and there's still something wrong, and it could have been fixed with surgery or early intervention through us. So I'm going to list all the things here so I don't forget them, and then we'll go through. So we call that a left ankle, and that's the fibula. Alright, so if we start here, easy stuff. Fractured fibula. Work down a bit, ATFL. Now with that, in here, syndesmosis. So you've got AITFL / PITFL / syndesmosis. So that's at the back, obviously, the PITFL. You've got your PTFL. There, you've got your CTFL. So they're all pretty common ones that you guys would no doubt all be familiar with. And if you work a little bit further down the foot, then you've got cuboid or cuboid syndrome as well. There. Metatarsals, 1 to 5. If we start then moving over a bit more medially through the foot. So navicular, very important one that gets diagnosed correctly and early. Can have acute fractures and common stress fractures in that as well. Further up the foot then, extensor retinaculum, toe tendons, on the dorsal side of the foot, okay? Then medially, deltoid ligament. Okay. Underneath the foot then, we're talking plantar surface. You've got, again, all of your flexor tendons. You've got your plantar fascia. You've got various different nerves coming through the foot. You've got your sesamoids further down the foot. Back over on this lateral side, which I forgot about, you've got all of your fibularis tendons. Anything else? Probably. Yeah.
So I'm not sure if you wrote mentioned there on the medial side, just so Harbour tendons.
Yeah, yeah. So Tom, Dick, Harry, go with them. Os trigonum at the back as well. / posterior impingement. So that's a lot of things more than the ATFL there, aren't there? So we'll start with these ones because they're easiest. So Kim, have we got a bed that we can?
There's nothing just behind you in the cupboard there.
Yeah.
Otherwise, next door to that coverage.
All right. So best way to diagnose a fibular fracture, what do you reckon? Sorry?
Palpation.
Yeah. Poke it. Someone give us a hand there. Cheers. All right. So, Luce, jump up for us. There he is, the big dogs. So, fibular fractures. So ankles, when you sprain them, inversion sprain, someone comes in, says they landed like that, don't forget proximal as well. You'll see, not commonly, but not uncommonly either, people can sprain their superior tib-fib joint as well as get fractures higher up the leg when they've sprained an ankle. So, good evidence behind poking all the way up the fibula, being able to diagnose not necessarily a fracture, but at least that there's something wrong somewhere along that bone. So make sure anyone comes in with anything down low at the foot here, that you're palpating up around the knee as well, so they don't go missed. X-rays will show those often. If they're bad enough, need surgery. Alright, so you guys would all be pretty familiar with all that from uni. ATFL, common one. From uni as well, you get taught this so many times. Fibula, down here. Easy, top of the talus, angle, roughly there, like that. How do you test it? Anterior jaw. So scoot down for us. Stabilising, have the foot sort of neutral, draw anteriorly. Alright, so they're the common ones that you guys will be good at already. Now, syndesmosis / AITFL. Does anyone know much about that? You can say no. Alright, so what's its job? If this is our ankle here, alright, so there's a ligament at the front between your tib and your fib, and at the back between your tib and your fib. So what's its job, function?
Transmit force from the foot to the leg.
Part of it, yep.
Stop the tibia fibers.
Yeah, splaying. So, when I'm walking and I dorsiflex, the tib-fib ligaments stop the tib-fib splaying. Alright? So what do you reckon mechanism injury of that is, more commonly? That kind of thing. So it's kind of like a medial deltoid ligament sprain. So someone can have their foot stuck like that, people fall that way, and the foot gets ripped up into sort of abduction, external rotation, dorsiflexion, splayed ligaments through there. Okay? They will get pain laterally as well. So I reckon throughout my time, these are the ones commonly that come in 10 weeks later from the GP for a lateral ankle sprain, and they're still sore. Okay? They're missed because it's a similar area of pain. Now, so ATFL roughly here, okay, these AITFL ones don't swell as much. So that can be a giveaway. You would have all seen the ATFL here, people coming with those massive fat ankles. AITFL is up roughly through here, and it doesn't swell anywhere near as much, as a rule, as a straight ATFL sprain. Problem being, if the trauma is significant enough and you've done more damage, swelling comes as well. So, not necessarily that reliable. So how are we going to test them, those ligaments that are more reliable? Yeah, we've done this, so you're cheating. So what's its function? stop splaying. So what are we going to do? Make it splay. All right? So if that's the mechanism often of injury, the abduction, external rotation, dorsiflexion, we do it. So bring them up there like that, pull up that way. Now this is a pain test. So the evidence tells us these tests, as opposed to say a Lockman's at the knee where we're trying to feel what's happening, you can't really feel very well, oh, that feels more sloppy than the other side. It's a pain provocation test. And of all of them, this one has the best sort of reliability. So external rotation or eversion, dorsiflexion, pull up, does it hurt? Now what you'll think when you first start seeing them, if someone has a really big fat ankle and they've got an ATFL sprain, you'll think everything's going to hurt them. Now in my experience, if their syndesmosis is okay, even if it's really fat and swollen, you can do that test fine and it doesn't worry them. They go, yep, that's fine. All right, so it's relatively reliable. Now there's a really good article that's got about 5 or 6 tests that you can do. That one, I reckon, is the best of them. However, do all 5 or 6 that I'm going to show you now. Kim?
Yeah, I was going to ask another test.
Yeah. So that one is the best, I reckon. Now, other ways you can do it. If we're trying to get it to splay distally, you can compress proximally. So if you have the fib here, make sure they don't have shin splints and things like that as well, because it can be really painful on people with medial shin pain. Squeeze proximally, see if they get pain down low. Now, my experience rather than evidence-wise, if they're getting pain with that test, it indicates a more severe injury. I don't know what anyone else reckons if you've seen them, but indicates a more severe injury in my experience rather than evidence-wise. All right? You can also, if you just sit that way, legs over the edge of the bed can be the same thing. So squeeze higher up here. Do they get pain at the ankle? You can do that test down here as well. All right? Other thing in the literature is tapping. So tap down near the calcaneus, like that. Do they get pain up through the ankle? I suppose the theory behind that is that you're just putting force up there. Is it going to splay? All right? So any ankle that comes in with lateral pain, don't just palpate the ATFL, have a feel higher up as well, and try and assess those high ankle sprain tests. Now, for the more minor ones, so just like you can have grades of severity of an ATFL injury, you can have grades of severity for a syndesmotic injury as well. So someone comes in, they might see you on a Monday after playing that weekend, they're getting higher lateral ankle pain, but they're able to weight bear, they can walk. They say, oh, I just get my pain as I'm going towards toe off when I'm walking. Have a stand up, please loose. So you can get those people to lunge. Does it hurt? Yes, that's going to hurt them because as you dorsiflex, the AITFL does its job. All right, you can get down, pressure around the fibula, pressure around the tibia, down near the malleolus, squeeze together, lunge. Does it feel better? They'll say yes. Okay. You can also, with that one, measure it. So get them to do a knee to wall, pop the pressure on, do a knee to wall again. Does it get bigger? That's a positive test, their distance. All right? So definitely keep all that in mind. Now, AITFL, PITFL, syndesmosis, so they all work together. So
with the lunge, are they getting further if it's positive and you've done it, or?
Yeah.
Yeah.
Yeah, so a positive test is I can get further.
Yeah.
Okay? Still, I don't measure that when I'm doing it. I'm just looking for pain with that stuff. Okay? So then if we talk a little bit about treatment of this stuff, lots of conjecture going around of how best to treat things. So, imaging. What do you reckon imaging will tell us? Any ideas?
Not much is supine, you probably need a weight bearing shot.
Yeah. So they're the sort of people, like we mentioned before, they go, get an x-ray, it comes back normal. So the GP says, oh, that's fine, they don't need any more intervention. Often the GPs say, you don't even need to see a physio, it should be fine in 6 weeks. And then we see them. Now, it's more of a surgical kind of decision, but if they've ruptured all of this stuff, they're going to need surgery to fix it. So how are we going to tell? If someone comes and sees us, a weight-bearing x-ray, where they measure, and you have to request these measurements of the syndesmosis. So what the radiologist will do is take a picture in supine, and if this, is the ankle kind of mortise like that, and it ends up being that wide, they've got normal measurements for those distances. And if it's going to change a little bit on weight bearing versus non-weight bearing, if it changes within certain amounts, they'll report that as a positive finding. All right? So that's a simple, easy, reliable test for us to refer for. To really see how much damage is done to all of these different ligaments, MRI is the gold standard with that. When it comes to treatment, I've been to a few different presentations from different surgeons of the best way to manage these problems. As a rule, if it's sort of one of these damaged, think of it as a normal ankle sprain, but it might take double the time. All right? They might go in a boot for a period of time and be non-weight bearing for a period of time. If the whole lot is ruptured and their foot is just splaying, how they manage it over here is they put a screw in between the tib and the fib for about 8 weeks. Then at 8 weeks, take the screw out, get the ankle moving again. Some surgeons do what's called a tightrope technique, where they put a tight rope in between the tib and the fib, and they leave it forever, and you can get them moving much more quickly. So there are a couple of different options that are a bit above our head, but just be aware that if you see tightrope or something on a referral from a surgeon, you know what they're talking about. And it usually means you can accelerate it a bit quicker. The screw needs to come out at 8 weeks if they use a screw, because otherwise you're not going to get any range of motion back. Okay? Does all that make sense to everyone? Cool. So, say they don't need surgery and we're treating it like a double length ankle sprain. So, stability versus mobility, what's more important in general?
Mobility.
You can probably argue either way, can't you? So, you need both. If your ankle's unstable, moves too much, you're going to keep rolling it. If you've got no mobility, you're probably going to get problems further up the chain. So, in this scenario, if the person is unstable down there and we get them weight bearing too soon, the tib and fib are always going to splay until it stabilises. So, through my experience, I don't know what Tony reckons when treating these sorts of things, these are the ones that I tell people, let it stiffen up first, so at least we know then your ankle's going to be stable. Once it's stiffened up for a couple of weeks, that's when we hammer them with treatment to try and get range of motion back. What do you reckon?
Yeah, I would have said stability is more important first.
Yeah.
It also, I guess, in making the decision, is it a person who's hypermobile or is it a person who's really stiff?
Yeah.
Would also.
Yeah. So the take-home message from all of that stuff there is it's really, really important. It's probably underdiagnosed, especially from GPs, and the treatment is not the same as it is for this stuff up here. So it's really important to get it right. And with doing those simple tests, can change people's course of how their ankle progresses. Okay? So be aware of it. The real intricacies of it the evidence is pretty sketchy on it, and it's kind of touch and feel about how they're progressing with things. All right?
Hanbury did his on the weekend.
Who?
Hanbury.
Did he?
Hanbury.
Yeah.
He's in a room for 10 days.
There you go.
Steve Cam was just mentioning, do we still tape them?
Yeah, so that's what I'm going to take you through that stuff in a little bit of different taping techniques and some fancy treatment techniques that we'll go through. All right. Posterior tib fib, talo fib, similar to ATFL. CFL, you've done that before, so that's your talar tilt test. So that's going to go from there to there, roughly. All right. This is going to hurt on everyone that's just done an inversion sprain anyway. So moving there, comparing it to the other side. Okay, you would have all seen that heaps at uni. Now your perineal tendons. So that's can be acute, can be chronic. So if you've sprained your ankle and you've landed like that, all your body weight's gone through, it's probably pretty reasonable to think that you've stretched your fibularis or your perineal tendons, right? Yep. So we all know that they come down here. What attaches in here? Which one? Anatomy quiz?
Rivers.
Yep. Where does longest go?
Base of first metatarsal.
You guys are geniuses. Yeah. So one comes in that way, one comes around all the way up to the base of the first through here. Fibularis tertius, where's that?
Cuboid.
Everyone's too smart. Right? So what do? You all know what they do. Evert, okay? And because they come round and sort of underneath the foot, they have a bit of a plantar flexion roll as well. So when assessing those, you guys would have all done it hundreds of times. Pull out. Does it hurt? Is it weaker than the other side? So that's one I reckon when an ankle's really swollen, pain inhibition, they're not really going to be able to do that anyway. All right? So if it's more chronic then, people coming in with pain down here, all right, what are you going to do? You want to differentiate. Is it ligamentous? Is it bony? Poke them. All right, so if you resist loose, so you can see one coming in here, okay, and you can follow, and the other one's just there. You can follow them around the back of the malleolus all the way up through here and find, just relax now, and then find where it's sore. Okay, they can get tenosynovitis through there, respond really well to injections. Our job with that stuff is probably to figure out why they're getting sore there, so foot mechanics sort of stuff, or is it problem further up the chain that they're overloading through the lateral side of their ankle. Alright, so don't forget those. So you can tear that acutely as well. Alright, so you can be suspicious of that if they've got no eversion or it's markedly weaker, more so than just sore than the other side. And don't forget, fifth, okay, so the brevis tendon can avulse off the fifth in a ankle fracture, and that's in your Ottawa rules that you would have all got hammered on at uni. So always palpate down there as well. Okay? Any questions on that lateral stuff? Didn't think so. No one ever speaks, do they? Alright. So if we go then to cuboid syndrome. Symptoms of that? Anyone? What do you reckon about pain around the cuboid? Fair? Yeah, sweet. So cuboid, where is it? Alright, don't worry, I won't ask any more questions. Here. Now, so that bone you can get at from the dorsal side and the plantar side. Alright? Now, it's a bit more of a manippers thing, I think, rather than us sports guys, but you can manipulate the cuboid and it can give people instant relief. Yeah, the old shotgun, is it called? Yeah. So the trick behind that though is you've got to work out whether it's displaced plantarly or dorsally. All right, now I don't really think I've got the skill to do that, but if people are getting pain out there, sometimes they might then complain, oh, it feels like there's a bit of a stone in my foot just underneath cuboid there, like that, and you can manipulate it. Do you want to roll onto your front, please, Luce? So they will complain of pain here, through like that. There, you poke at it, it gets sore. Now, if you just scoot over to the edge. Now, I've seen a few people do this a few times, so you can have them there, get your finger on the cuboid. Now, you MNITS chiropractors might do this better than me. You feel through there, like that, and go harder at it, and you can feel it click through there. All right? That's for the ones that you think might be displaced inferiorly. Flip back over. Other technique is they think that you can displace it dorsally, so then you can mob, stabilise around the calcaneus, so it's calcaneal cuboid joint, stabilise distally, and mob downwards, like so. And I think you can manipulate that way too, can you?
It's probably more stiff than displaced is the way we think of it. It's
Yeah, okay.
holding it.
So there you go, that's stiffness. All right. So for that sort of stuff, when I see those people, I just sort of think, oh yeah, it might be a bit stiff, let's mob it one way, see what happens, and then try and fix whatever biomechanical problems that I think might be causing it. Okay? But be aware, pain around the cuboid. Okay? Next stuff. Metatarsals, 1 to 5. So obviously you can fracture those acutely. All right, mechanisms. Direct pressure, car driving over your foot, a common one that I've seen when people waiting for taxis. Car just drives over your foot.
Bus foot. Bus foot.
Yeah, I've seen, I reckon, well, common meaning probably 1 or 2 a year, but people on the piss, foot, step out, taxi rolls over the top of it, any kind of direct trauma there. Now, Simon went through this a few weeks ago in the masterclass, stress fractures. All right, so we'll talk about probably the midfoot here now as a whole. So stress fractures in this area can be career threatening. So it's important, extremely important, that they're diagnosed correctly and quickly. So anyone complaining of midfoot pain through here, always touch the navicular, all right, the end spot it's called. So navicular bone around here, similar location sort of to scaphoid in the wrist, it's what I liken it to, and it's got poor consequences if it's not treated properly as well. So that's the navicular tuberosity here. Okay, that's the knobbly bit you can feel in your foot. The true end spot is a bit more dorsal like that. Now, people with stress fractures of that won't let you touch it. They will jump and kick you away. That's a pretty reliable diagnosis right there for a navicular stressy, all right? Or even a navicular acute fracture through there. Now, what would we do with that? Refer on. Yeah, MNIT, cuboid, do all that stuff. No, refer on. Because like Simon was talking about the other day, there's lots of different scans that can be done for it. MRI. So MRI will give you a good look at the bone, all right, of is there inflammation of the bone, but it can miss fractures through there. CT scan of that has got a lot of radiation, but gives you a really good picture, is there an actual fracture line through the bone or not? Bone scan's got a lot of radiation and it'll just show increased uptake. So my opinion on that sort of stuff is, if you poke at it, we're pretty sure that there's increased uptake through the bone anyway. There's something not right going on there. So refer on, let the doctors make those decisions. And in my experience, they usually go for an MRI. It's got no radiation. It can show if there's huge bony edema through there, and they treat it the same anyway in terms of unloading it to start with. And then if they're really suspicious of a fracture, they can refer on then to the surgeon, who will then decide. Does that make sense? Haven't contradicted myself too much there? No? So, be aware, navicular stressies. Further down the foot slightly, Liz Frank ligament. Anyone heard of that? Yeah, that's
How good
good.
are the toes?
Yeah, they're
It's
nice.
much better in Kim. Where's your foot?
Yeah.
They're ridden away.
So Liz Frank ligament, what's that do? Anatomy gurus?
Restricts a lot of dorsiflexion.
It does something in the foot to hold it together, basically. That's what I know.
Guys, so that's a level of answer that you can actually pitch at, all right?
Yeah.
It does something
Yeah.
in the foot.
Yeah.
So feel happy and confident.
Yes. So you'd probably know more with that than me. It's extremely important though, all right, in midfoot stability. Mechanism of injury. So these are the people that are usually playing sport. They dive for the ball down here. Then their foot is in a plantar flex position like that. And then someone jumps on top of them to try and get the ball. And all of the other person's body weight goes through that plantar flex foot in a axial loading pattern. So they land there like that. And that's going to hurt lots initially. All right. So, look, the Liz Frank ligament is one ligament that goes from, I think, the middle cuneiform to the second metatarsal, somewhere around there, like that. But in my experience, there's so many ligaments through there, and if that part of the foot becomes unstable, it's called a Liz Frank fracture or Liz Frank ligament sprain. All right. So to make that relevant to us, people come into the clinic or you're at your sport, whatever it might be. They say someone fell on their foot like that. They've got pain through this part of their foot. They're struggling to weight bear. It hurts to touch through here. Then that's something that needs on referral as well. Okay. Now, best type of scans for that, you can have an X-ray, like the same how we were talking about with the syndesmosis, weight bearing versus non-weight bearing. Do the metatarsal splay when you weight bear, and then an MRI will just give you a good picture of those ligaments. All right. How do they treat it? So if it's bad enough, they put screws through all the little bones around the foot there to try and stabilise it. That can then create problems further down the track because, as you all know, all those bones in your foot and joints are really important at load transference. So if you then go in and fuse those bones, the load is not getting transferred how it normally would be. So you want to try and avoid that if you can. And then a period prior to that, a lot of surgeons will say have a period of non-weight bearing, see if the foot can stabilise, and then gradually progress them back from there. Okay? Take-home message though is pain through there, refer on further up the chain and get guided with your time frames from there. Alright? Metatarsals. So acute fractures, poke them. Stress fractures, poke them. Does it hurt? Fairly simple there with that. If you're worried about a stress fracture, refer on. Okay? So how can you then differentiate between something where you're worried about a stress fracture and someone's just got a bit of a sore foot because they've done too much? Kim?
Asking about the pain behaviour, whether it settles after the period. If stress reactions assume increased loading, going to make it feel worse. So hot compared to just walking,
Yep.
jumping.
Yep. So key ones, I reckon, night pain. Is it hurting when they're doing nothing? When they're training, does it warm up and feel better? Or does, when they warm up, every step they take, it gets worse? All right, so if they're getting pain through their midfoot there, they say they warm up and it starts to feel better, take that as a bit of a warning sign, but it's probably not as stressy yet. Okay? Take that carefully though, and don't quote me on that stuff. Alright? But definitely, if they warm up and then they just can't take a step, you're starting to get a bit more worried about things. Okay? Can happen in any of the metatarsals, but more commonly second, third and fourth. Alright? So you can poke on it dorsally and be systematic with your poking. So you can start at the toe, work up, do that on each one. You can come under on the plantar surface as well and even sort of squeeze and see what reaction you get from people. Alright? Calcaneal stressies. Similar sort of symptoms. Key test for that, squeeze. So just get around the back of the calcaneus. You can do it on yourselves and squeeze fairly hard. You'll realise that it's not meant to hurt. People that have stressies there, it will hurt, and acute fractures, it will hurt as well. So remember, squeeze test around the calcaneus. Alright, have we covered probably those? Down here now. So extensor retinaculum. So you can think of that, if we relate it to the wrist again. So extensor retinaculum, kind of like carpal tunnel syndrome. Alright? Now these are the ones you'll see, and it's almost a diagnosis when nothing else fits. So these will be your crazy marathon triathlete sort of people. Then they'll come in and they'll go, I get pain at the 42k mark of my 60k run, and it's just a vague pain through here. And you think, you do every single test you've ever done, known to medicine, and nothing comes up on it. Because it's pretty hard to get people's pain happening at the 42k mark when you're sitting in a clinic. Alright? So what they do there and what the theory is, I've seen a couple of these in my career, is that for some reason the extensor retinaculum is too tight. So where all of your toe tendons pass underneath it, as you've been running for 42 Ks, fluid builds up. That sort of happens naturally. And then at that point, everything becomes too tight and you get symptoms starting to occur there. So what they do is go in and release it.
Just loosen the shoelaces.
Yeah, that kind of analogy. So that's an easier step, but the analogy's right. What Tony's getting at there.
Sometimes it is from the shoelaces.
Yeah. So yeah, be aware of that in your ultra distance runners. Now, when we're then talking about stress fractures through the metatarsals, sitting on top of the metatarsals are the extensor tendons. Alright? So that's where your subjective questioning becomes important as well, and your objective testing. So if you just use your palpation, you're not necessarily sure, am I just compressing one of the extensor tendons onto the metatarsal, that's why it hurts, or is it bony soreness? So what are you going to do? Help you differentiate? Easy? Perfect. So bring your toes towards your face. Does that hurt? Yes, they'll say. Bring your big toe towards your face. No, that's okay. So you might have tenosynovitis on one of your extensor digitorum longus tendons. Okay? Motor control around the foot. Ben Raysmith, my old boss, is doing a study on this at the moment. Benny's a great man, regardless of what others would say. So everyone take your shoe, one shoe and one sock off now for me, please. Some of you will be good at this, some of you will be horrendous at it. So this all came about through Ben's doing a study at the AIS on shin splints, and it got started by him treating people. Some people come and see you where they say they've been doing extra running on hard surface and their shins get sore. Some people will come and tell you, I've done a heap of sand running and my shins are getting sore. So they started to think, with all the gurus over there must be two categories with this. So one being only soreness in your shins, one being something to do muscularly. So then they started looking at motor control of people getting these problems. So if you have your foot in front of you like that, you can put it on the ground. If you keep all of your little toes on the ground and move your big toe up and down. So some people will be good at that. Some people will be ordinary. Then keep your big toe on the ground and move your 4 little toes up and down. Now some of you won't be able to do it, and some of you will have to, and I can see it, really like grind your big toe into, almost pin it down, and then use your big toes coming up. Then if you try this, if you lift all of your toes up, keep your big toes still and move your little toes down. Then do the opposite. Keep your little toes still and move your big toe. Alright? Now, what that really means, I don't know yet, but the theories of where it's getting to is just like with more of your proximal stability, there's motor control, and people have motor control deficits around the foot. And with those elite level kind of athletes, when they're trying to tick every single box, is they're trying to improve people's motor control around the foot as well. And that can be something you do with your patients just for a bit of fun, if you want to. And you'll see that some people can't do it, some people are pretty good at it.
Do you have to pre-activate your pelvic floor?
You do. That's a prerequisite. Yeah. Yeah. And multifidus. Okay, don't forget that. So we've done those. Toe tendons, extensor retinaculum. So Tom, Dick and Harry. So they are your tendons on the medial side. So we won't go into those too much. You all know where they are coming down the medial aspect, and you can get those to initiate, what's that, inversion. Can you invert for me? Yeah. Flex your big toe, flex your little toes. So those muscles attach roughly up here, right? So as they come down and underneath the foot, people getting foot pain, by the same token, don't automatically just think, oh, it's plantar fasciitis or fasciopathy. Test each of those tendons as well and try and palpate where they come along. I have seen, I think, 3 in my career of people tearing tendons through the bottom of their foot. And I've seen one guy tear it, I can't remember which one now, but a tendon somewhere up around the ankle as well. And that he was a footy player and a firefighter, and his wife was a GP, and he was playing footy, and he just said he felt a little pop through the medial side of his ankle as he was sprinting and to jump up and take a mark. He felt a little pop through here. When we had a look at him, there was fluid, like he had this really defined area of puffiness around the medial side of his ankle where everything else was fine, and he had pain with whichever tendon was torn when he was flexing some of his toes. Okay, so that just got treated conservatively. They just need a period of rest, but probably needs scanning and referral to a sports doc because it's pretty uncommon, and an ultrasound scan is fine of that. Alright, but definitely check the toe tendons as well. Flexor tendons we talked about there. So plantar fasciopathy or itis. So most common subjective complaint that those people talk about is, makes you think that's plantar fasciitis.
Pain around the plantar fascia.
Then the second most common,
In the morning when I get out of bed.
First step I take kills me. As I warm up, isn't too bad. That's what they'll complain of. They'll point to a really specific, let's move that one up for me. Really specific spot, right here. You poke on it, it hurts, okay? Because there's lots of other structures, so intrinsic foot muscles, etc. running along there, other structures can be implicated as well. So then if you're doing your resisted toe tests, that might hurt them a little bit as well. So our role in that condition, figure out why it's happening. So same thing, proximal stability, foot mechanics, etc. Do we need to change do they need podiatry referral? Do they need orthotics taping? Anti-inflammatories help, ice helps, and anecdotally, I'm not sure evidence-wise, I don't know that much about this to be honest, but rolling over the frozen Coke bottles, I've had plantar fasciitis myself, it helps, but is there evidence behind it? I'm not sure. Don't know if you guys know.
There's no research done.
Yeah.
I think what it does, it relates back to frictions.
Yeah.
So tendon frictions, which now with the latest research in tendon, the concept is that you're changing a chronic inflammatory process into an acute inflammatory process.
So with me thinking about that logically, it's probably not right, but it helps. So I do it. Yeah.
You might also be diagnostic if you're trying to differentiate between like a nerve irritation.
Yeah.
If the nerves will probably get stirred up if you're doing frictions.
Yeah, that's a good point. Yeah. So if we're talking nervy stuff now, lots of nerves in the foot, subjective thing that's going to point you towards that. Easy one.
Numbers.
Yep. Numbness, pins and needles. Now the hard bit, just like with upper limb neuropathies, they come realistically anywhere from the brain to the toe. And it's our job to try and work out why. So bilateral stuff, other conditions, is it something from the spine? Is it piriformis? Is it a red flag kind of thing like GB, or you know, they had cancer before and getting back pain, pins and needles in the foot? Is it something like the extensor retinaculum? All sorts of different things. So that needs to be assessed thoroughly if you're getting pins and needles and numbness. You all know how to do your lumbar things, your reflexes, sensation, all of that. So pins and needles, numbness, definitely assess all the way up the chain. Figure out where you reckon it's coming from. Okay? Sesamoids. So what do you reckon people complain of when they have sesamoid pain?
Pushing it.
Yeah. It's all easy stuff. So they say it hurts where their sesamoids are, and you poke it and it hurts. Alright? Sesamoids are here. So when you get an x-ray of the foot, people have often bring it in and go, oh look, I've got 2 fractures through my big toe there, that's why my toe's sore, and it's probably not, but they've got sesamoiditis. So how do you treat that? Unload it. So they don't necessarily need to stop everything if they're not bad enough. There's a really good picture of it in Bruckner and Kahn where you can cut that Lucafoam patty sort of stuff and have it all here coming down that way, and then just cut a bit of a semicircle out, so then when they're in their shoe, the sesamoids aren't getting weight going through them. Okay? You can have them taken out. One guy at Footy's had that done, but it can create problems further down the track because their function is like the big FDL tendon runs past them, and they act as like a fulcrum or something like that. Again, I don't know a whole heap about that because I don't see it enough, but it can then create problems with your foot mechanics if you take them out. So that's kind of a last resort. Okay?
Steve,
Yeah.
sesamoiditis, because it comes, what I haven't seen much of it, I understand it can be pretty complex. Will you refer that off Or will you try and manage
No, I
yourself
just try and
initially?
manage it initially and then refer off if they're not getting better. Yeah.
They act like a kneecap.
Yeah.
So you lose power if you don't have them.
There you go.
And they're in the tendon, of course.
That's better articulated than how I said it.
So if you have them removed, it's fairly major surgery.
Yeah.
Shakes down as well, don't they?
What's that, sorry?
They shakes them down as well, don't they?
I haven't seen that, but I don't know. Alright, so we'll show you some like more funky sort of stuff now, I suppose, for you. So, and this, so out of all of that, that's just stuff that I thought of off the top of my head. There's probably a lot more than that to go on. So just when people come in with foot and ankle stuff, don't just think ATFL. At least assess all this other stuff. And it doesn't necessarily take that long to do quick tests for all of that in your treatment time. If you think that it's something that needs referring on, do it. If you need assistance from someone, at the clinic with you, you can do that as well fairly easily. Alright, so we talk a little bit then about treatment. So obviously the treatment for all of those things is different. So if we talk more generally now, so someone's got a stiff ankle, what helps with that? Moving it, yeah. How many ways can you move it? Lots. The key is finding out which way it needs to be moved, I reckon. So knee to wall test has really good reliability behind it as a measure of ankle range of motion. So I always do a knee to wall. Simple. Have your knee touch the wall, move your foot as far back from the wall as you can so your knee touches the wall. Keep your hips square so they're not getting rotation and cheating on it. AP mobs of the ankle work extremely well for dorsiflexion limitations. Extremely easy to do, and you can have a good chat to your person as you do it. Now how I do it, I stabilise underneath here, set them up all nicely so they're comfy if they have a towel or whatever it might be underneath the knee. Come underneath, take up all the available range of motion so that they're at the end range. Some mistakes that you'll see when you're learning this sort of stuff is people might be too high up and you're missing the talus, so you're coming up more onto the tibia. So that's not going to do much to the ankle joint. So make sure you're coming and gripping the talus. How I do it's like that. And I do both for some reason with my left hand. So I stabilise under there, come on top of the talus like that, take up the available range, and then mobilise down that way. Now I'm not sure how you're taught at uni these days, but I think, it may be to stand sideways like that and push down. Does anyone do it that way? Yeah. So that, however you do it, that's not wrong. I just reckon for me, so when they're getting, so if their ankle's really stiff and they're struggling early, you can do it like that pretty easily. But when they get more range and you're wanting to keep it at end range, I find it gets a bit awkward if you do it that way.
So painful if your pressure is over the ATFL.
Yeah, true. So for me, I put the bed down relatively low, stand there like that, and mobe that way. All right?
It's also a lot more mechanically efficient for the therapist to do it that way, I reckon.
Yeah.
You won't be as tired by the end of the day.
Yeah, spot on. Now,
sometimes you put a towel between your body and them too if you don't want a foot on your leg.
yeah, I do that all the time, I think. Yeah. Now, other kind of foot mobs. Now, I haven't gone into it
Actually,
too
Steve,
much.
what you actually do if someone comes in with a sweaty foot is you say, next time you come in, it's a really good idea if you soak your foot in warm water,
Yeah.
or if it's an
Menthol,
acute, cold water,
lavender.
because
Yeah.
that'll help it heal better.
Or see someone
rather than
else.
wash your feet.
I do that occasionally, like book them in with Baz. They're really stinky. Sorry, mate, I can only come in the arvo.
Should look at them for Lucy.
yeah.
Oh, sorry.
Now, I haven't gone into it too much today because we're talking more about acute stuff, and the way I treat, I reckon I don't have a great knowledge on midfoot and forefoot biomechanical type problems. So trying to work out whether people are stiff or hypermobile through those foot ligaments and joints, I reckon can be quite difficult to do compared to a knee. So if you have a knee, it's unstable, it's moving too much. So I get help from the podiatrists with that. I might refer to someone like Fabio, who works in West Perth, get him to assess them. And he's really good because he sends people back. He'll assess their biomechanics for me and say, oh, I reckon they need talonavicular joint mobs or whatever it might be, and then sort of go on his recommendations. I don't know what you think, Tony.
I just encourage everyone to get to know feet.
Yeah.
Don't be so worried about textbook mobilisation. Get in there and see how feet move. Get in there and see how your own feet move.
Yeah.
It's a whole world. There's that many joints in there. And
That's
you
right.
do get an appreciation of how things feel, and particularly if you're comparing left to right with someone, you find that, oh yeah, that joint doesn't feel right. Even if you can't name the joint, but you can feel it, then that's a bonus.
Yeah. So common sort of things that I reckon that you can see. So talonavicular joint, and TMT through here, through the first ray. So if people are getting too much load going through their navicular, right, and they end up with a stress fracture or a stress reaction there, it's probably clinically reasonable to think that the joint's not moving that well either. Does that make sense? So if the joint's not moving well, lots of load going through that navicular bone. So to mobilise it, now is this thing safe, this Pilates machine?
Not like that.
It's like that, alright?
Yeah.
They're the devil, hey? So I grab a wheelie stool. I reckon we're sweet. I'm all good now, yeah. So I can come in there and stabilise on top of the talus, like so. Grab onto the navicular. It can depend on people's size, whether you need, it's quite a big foot to grab around like that. Small foot, sorry, other way around, big foot like that, small foot like that. I stabilise the calcaneus, so that's not moving at all either. So if I don't do that, that's not wrong doing this kind of mob, but it's much more general. Whereas if I come in here, stabilise talus, calcaneus, grab a hold of the navicular, and you guys probably sitting there can probably see it can be quite specific to the talonavicular joint. Now you can move it that way, you can move it that way. So the theory being if it's stiff, move it, and it's kind of like an ankle, it might be an AP or a PA, where this joint you can move dorsally or in a plantar kind of motion. Other ways I've seen things like that done by foot physios. Have we got a towel?
Just keep in mind the foot's really strong, like it takes hundreds of kilos of force.
That's
when you're
right,
running,
so that's
you
what
can
we
really get into those joints.
So that's what we're going to show now as a brilliant segue. So move that one up. Actually, move both up. No, stay there. So if we're then thinking along those lines, so they're getting better and you want to mimic the running action. So you're like that. You can put the toe in a bit of extension. Does that work if you're down that way? Yep. So you can put the toe in extension like that. I'd have the bed higher. The bed stabilising the calcaneus there for me, and come into a similar sort of position here around the talus, get onto the navicular, and then really jump on it. Okay, and get a lot of movement happening through that joint through there. Now I'm not saying do that on acute stressy for obvious reasons, or if someone's foot, so Lucy's arch is quite high through there, so if their arch is really flat like that, I'm not going to then jump on it and make it more flat. Okay, but for this kind of foot type, through there, like that, get on it and jump really bang. I've seen people, doing that sort of stuff with it. So you can go as hard as they can take, and it's relatively comfy, hey? Does that hurt? Even if I...
At that, when you go a bit harder.
bit harder, yeah. So you can work out what they can take, what they can't take. Okay? But don't be afraid to use a fair bit of force with that. Now, okay, we might use this one. So calcaneocuboid joint, so same sort of thing, getting pain around there. It's reasonable to think it might be stiff. So I would sit down. It's going to be a bit hard to show you if I'm sitting, but I can stabilise through there, or put your knee underneath, stabilise the calcaneus, grab there, move their foot. So I felt that click. Did you feel that? So it's a manipulable joint for some reason. So you can grab on, move through here. Okay? Now, so they're the stiff ones. So if you're talking about hypermobility, so someone comes in mid-foot pain, like we said, I don't think I can assess an individual ligament through the midfoot. There's too many small bones. So you think, all right, let's give it a try. Let's mob it, see if someone gets better. They come back worse, said they couldn't wait there through the rest of the day after treatment. Then maybe you're thinking, oh gee, have they got a Liz Frank type injury? So it's an unstable joint. I've just got around and moved all of that instability and it's gotten sore. I've done that before on one lady, but she was lovely, so she didn't mind. She went and had an operation and got better. So clinically reason your way through things like that. All right? Some taping techniques we might do.
It's okay to make mistakes, as Steve was happy to admit. I had an East Perth footballer who I was acupuncturing his fractured fibula for 3 weeks and wondering why he couldn't run.
Yeah.
You learn things, you make mistakes, as long as you keep asking the question each time you see him, why is he,
Yeah. Yep. Now, so you'd no doubt, maybe I will grab that chair now from Cam.
Do you want a stool or is that good?
That'll be right, I think. Maybe we'll move you down this end loose and move around if you need to see things. Now, you've all done standard ankle taping before, so I'm not going to go through that. So we're talking about, if we talk about now syndesmosis injuries. Now, scoot down a little bit. So when the ankle dorsiflexes and invert/external or abduction, bones are going to splay. We want to stop that happening. This is a really good technique for that. The problem is it can create side effects around the Achilles. So we know about tendons now. Tendons don't really like compression. So you've got to be careful with this. As a minimum, people need fixamol up the back of their Achilles. So just relax. So as opposed to your normal ankle taping where they're starting like that, come around there, the tib and the fib, got Achilles protection on, come there, like so, around tight, either side, like that. So you can then get them up and lunge and see if it changes after that. Now I do 2 of them. 1, 2.
On a big ankle you might do 3, just depends how big the person is.
So you can see that that's not good for someone with Achilles problems. So then you've got to try and think outside the square. It's got a bit of a wrinkle in it, but that's all right for now. So there, can pull fairly tight, pull fairly tight, like that. Then when you lunge, so you can even see on loose, it's going to block a bit of the range of motion. I think that's probably why it takes people's pain away, more so than it doing a huge amount to actually hold things together. It stops them getting into that painful dorsiflexion range. And if you've ever had that or you try it on yourselves and do that, you'll realise that your ankle feels a bit stiffer after it. Okay. Really make sure you look after the Achilles though. All right.
It's a great tape, and being able to identify these injuries, it puts you above the average physio. I think it's really commonly missed, isn't it, Steve?
Yeah, I think...
Joint, and it's not hard to pick up. Even just from palpation, you can sort of go, oh, that hurts.
Yeah.
It's not complicated, but people miss it.
I think, I can't remember who did the study, but they said there's a prevalence of somewhere between 15 and 20% of all ankle sprains have that. Now we'd probably, see in a clinic like South Care, would probably see 30 ankle sprains a week. So if you think like that, there's probably going to be 5 or 7 ankle sprains coming in that have that sort of problem a week. Now, what's the Mulligan guy's name again?
Brian?
Yeah, Brian Mulligan. So part of his theory was, so you sprain an ankle like that, the ATFL comes from here to here, so you bring your foot that way too much, so the fibula gets drawn forward when you sprain an ankle. So what he thinks, and some people really love this kind of tape, just scoot down a bit more again, got to be careful again with the Achilles, that you can lay the tape down across the top of the foot like that, take up the skin slack, apply an AP glide to the fibula, so that's on there, pull the tape not too tight because it's going to annoy the Achilles, so you've got your AP glide tape tight around the front, loosen it up a bit around the back, and finish on the front there like that. Now what you'll see with that is that bit of the tape there is loose, and that's how you know that, well, it's meant to look like that. So don't be afraid or feel bad you've got wrinkles there, that's how it is.
That's
so,
again for a high ankle?
Yeah. Or even just a normal ankle. Yeah, so you can try that on people with a normal ankle. Even if you're doing some of these functional tests, you can do like that one, put an AP on it, is their knee to wall better? You can try that taping technique. So some guys I'll do that for, and then do a normal kind of stability ankle over the top. So what we're doing then is gliding the fibula back and then providing it with support. So it feels better when they're running, but they've still got the rest of the normal ankle over the top of it. Okay? Do you have any little tiny finger tape here, Kim?
We've got one that's really half. I can grab it.
Yeah, grab that, please. So there are a couple of extra taping techniques for you for ankles. Now, one we didn't talk about is posterior impingement. I forgot that. Did I write that up there somewhere? Yeah, down the bottom. Thank you. I'll do this one first. So, talking about those flexor tendons in the toe, they might be more common than we think now that I've gone looking for them after I've seen a few. Ways that you can help to unload or give toe tendons a bit of a hand. So you put an anchor around like that. Now, at footy I use the even skinnier one, those really tiny little finger bits of tape. An anchor, I use your middle toe. Can be hard to do, obviously. So an anchor there. So say maybe they have a problem with the flexor tendon that's shown on their ultrasound of their third toe. It might be torn, but they want to keep playing. So you can see anchor there, anchor there. And this tape is too fat for it. But I can then put a couple of layers of little tiny one and then relax. And then sort of bring the toe forward like that. So can you see what I'm doing there? Is giving the toe help at jumping. So those tendons are used when people are trying to jump and run and sprint. So I can do that and then, put the other anchors over the top of it.